Hello and welcome to this video lecture on endotracheal intubation. In this lecture, we hope that we can share with you on the few important aspects of performing an endotracheal intubation and the science behind it. These are the learning outcomes of this video series, for you to understand the anatomy of the upper airway, which is a very important thing before you can perform a good direct laryngoscopy and intubation technique. Recognize the indication and contraindication of intubations. You should also be able to list what are the important equipments being used for intubation process, and we're also going to show you the steps in performing endotracheal intubation and also recognize some of the complications related to it. Now, what is endotracheal intubation? It is basically defined putting a flexible plastic tube into the trachea in order to maintain a patent or open airway. So that is basically the process of endotracheal intubation. Just get a tube which is patent, put it into the trachea, maintain the airway. Now, sounds simple, but let's review some of the anatomy before we can do that. Now, these are some of the important features of the anatomy of the upper airway that you need to recognize. Now, the tongue, there's a big tongue, right, in front of the mouth, okay, just behind the mouth, sorry. The hard palate, soft palate, and continuous with the uvula. There's going to be some of your landmark that you're going to hope to visualize during this process of intubation. Epiglottis, behind here, or some people call it the small tongue. Between or behind the tongue and before the epiglottis, there's a cleft, and at this cleft, this is the place called the vallecula. Now, the vallecula is where the tip of the endotracheal, the tip of the laryngoscope should be placed during the process of direct laryngoscopy for intubation. Okay, apart from this anatomy, there are also some theories in how to align the upper airway. First, we have the three-plane or the three-axis theory, which is the oral axis, the laryngeal axis, and the pharyngeal axis. So this is the three-axis theory, which all the axes need to be aligned. The other theory that's have been put forward is what we call the primary curve and the secondary curve theory, where a flattening of this curve, the primary and secondary curve, will help to bring this visualization of the vocal cord much better. Now, these are the list of indications before you want to perform an endotracheal intubation. The first thing is actually if there's an oxygenation impairment. That's one of good indication to intubate. You found there is ineffective ventilation, also another indication. Now, severe facial trauma and a low GCS of less than 9. The reasons for intubation is that basically you are worried that the airway patency is having a problem, so you want to protect the airway. And the other thing is impending airway obstruction due to whatever reasons, an expanding hematoma or anything. Now, these are some of the contraindications for during using a direct laryngoscopy for endotracheal intubation. And upper airway obstruction, which basically has already really blocked the airway, is something like that. Something has already blocked there. You can't do an endotracheal intubation in that situation. Okay, someone having a major laryngeal trauma, where it really block or distort the airway, also a real contraindication for intubation. Okay, so when there is a contraindication for direct laryngoscopy for endotracheal intubation, other alternatives should be seek or be put in standby in order it's failed. Okay, now you also have to understand what are the equipment being used to do intubation process. These are some of the equipments that we use normally to help us intubate. This is the back valve mask, or people call it manual ventilator. We also need a working laryngoscopy, okay, with a blade. Usually for adult, it is a Macintosh blade, some gel to facilitate lubrication, syringes to blow up the curve or to pump air into the cuff, ET tube, stillet or introducer, some tie, okay, to stabilize the endotracheal tube after being put in place, stethoscopes, a suction, rigid suction yonker, and also last but not least some glove, and also oropharyngeal airway can help you to do the process of intubation. Now, after getting the things ready, positioning the patient is important. Now, what we're trying to do is actually we're trying to put the patient into what we call as a sniffing position. It's like sniffing the morning air. How do you get the sniffing position is by elevating the neck or elevating the head by flexing the neck and extending the head. Okay, by doing this, what they show is that by doing the sniffing positions, you are basically flattening the secondary curve, and also trying to flatten also or almost get it in line of the primary curve from here to there. So you're almost having a good visualization of the vocal cord. Now, let's see how a laryngoscope has been placed in order to do the intubation process. Now, first thing, actually you have to open up the mouth, okay, and then after that put the laryngoscope into the mouth. Now, laryngoscope usually come from the right side of the mouth and push to the center. Therefore, the tongue will be sitting onto the steps of the laryngoscope blade. Okay, and once you're able to push the laryngoscope blade further in, it will basically be sitting onto the vallecula. Now, once the tip of the laryngoscope has reached the vallecula, then the opening to the trachea with the vocal cords can be visualized. Okay, right, it's something like this. The uvula, putting the laryngoscope in, pushing it in, guiding in into the uvula, into the vallecula, will basically help you to visualize the vocal cord and the opening. Now, once the you already seen the opening of the trachea or the vocal cord, the endotracheal tube or ETT will be slipped in. Okay, we will have to slip the thing in through the mouth, okay, and into the opening of the vocal cord. Now, once the endotracheal tube or ETT has been put in, we need to confirm the placement of the ETT. Now, there are several ways to confirm the ETT placement. One is through direct visualization, where you can see the tube really passing through the vocal cord. The other thing is that we can do a 5-point auscultation, is that we auscultate at 5 different points on the chest and also the epigastrium in order to see whether the tube is already going in. We can also see movement of the thoracic cage, okay, when we back the BVM or the manual ventilator, the chest move in and out, or the other thing is fogging of the tube. This is where when you squeeze in, the fog clears up. When you let go of the back valve mask, the fog will basically come in and fog the endotracheal tube. The other techniques of apart from physical assessment that we can ensure the ETT placement is by doing an end-tidal CO2 capnograph followed. The other thing also is esophageal detector device, or colorimetric carbon dioxide detector. These are some of the techniques of securing, or basically um, confirming that the tube has already gone in place. Now, once the tube has already gone in place, we need to secure. Now, they are basically available, commercially available endotracheal tube tape secure, or we can use a tie. It's up to you, depends on what type of technique or available things that are available in your department. Once you have already done that, then only the tip or the end of the ET tube being connected to a back valve mask or mechanical ventilator for continuous ventilation. Now, these are some of the complications of endotracheal intubation that you have to observe. One is an oral injury, injury to the mouth, lips, or even breaking of the teeth. Okay, if the technique is not being done properly. Laryngeal injury is if you don't see, this thing happen usually if you don't see anything and just keep on shoving in the endotracheal tube, that also can cause vocal cord injury. So the best thing is actually, if you don't see the vocal cord, you don't see the opening, don't just shove your endotracheal tube in, and you have to be very delicate in handling the upper airway because it can bleed quite easily. The other complication is if you push the endotracheal tube too deep in. Instead of endotracheal intubation, it will become an endobronchial intubation, which normally the ET tube will go bronchus, okay, which leads to a single lung ventilation. Uh, and esophageal intubation also, one more complication you have to be aware. It can happen especially in patients with difficult airway or difficult anatomy, that we couldn't really visualize the cord or the opening of the trachea, and therefore leading the tube being pushed in, and it end up in the esophagus. The other way how esophageal intubation can happen is during movement. Once you initially the tube went into the trachea, but because of movement, lock, roll, turning, and so on and so forth, the tube got dislodged and goes into the pharynx and become an esophageal intubation. So in conclusion, intubation is an important procedure for everybody, almost everybody to learn, especially emergency doctors or anesthetists, because a lot of time the one that can kill patient very easily or quite fast is loss of the a patent airway. So it is an important skill for doctors to be well versed in it. The other thing is the knowledge of an upper airway anatomy, indication, and complication of the procedures are salient in order to perform a successful intubation. With that, thank you and see you again. Bye.